that Professor Etoh is not with us here in persona, but he will connect online.
So may I request Tsuyoshi Etoh from Oita University to talk on minimally invasive gastrectomy for locally advanced gastric cancer. Is it the standard of care? Dr. Tsuyoshi Etoh, please. He'll be connected virtually with us. Yes. Hello.
Yes. Can you hear me?
Yes, can. Please go ahead.
Yeah, thank you very much. My name is Tsuyoshi Etoh from Oita University, Japan. Today, it's my very honor to present in your Congress. Thank you very much for kind invitation. Okay, I'd like to talk about the minimal invasive gastrectomy for locally advanced gastric cancer. Please start my video, please.
Good morning, ladies and gentlemen. It's my great honor to present in this symposium.
Dr. Etoh, the
This
video is
time
being
I
played.
want to go there, but COVID-19 sessions still continue. So I'd like to present on web. Today, my topic is minimally invasive gastrectomy for locally advanced gastric cancer. Today's contents are: first, I'd like to show global evidence of lap gastrectomy, especially for advanced gastric cancer, including our trial. Second, what's new next clinical question based on these evidences? Third, future perspectives of minimally invasive surgery. I'd like to mention where we go. First, I'd like to show global evidence of lap gastrectomy for gastric cancer. To solve our clinical questions, high-quality randomized clinical trials have been conducted mainly in East Asia, including Japan, Korea, and China, shown in the slide. According to Japanese Gastric Cancer Treatment Guidelines 2021, laparoscopic gastrectomy for clinical stage 1 cancer has become a standard treatment based on our evidence, JCOG 0912 and JCOG 1401. Regarding advanced gastric cancer, RCTs from Japan, Korea, and China demonstrated that short-term outcomes of lap gastrectomy were favorable compared to open surgery. In long-term outcomes, KRAS-02 study and CRAS-01 study have successfully showed non-inferiority. As for Japanese trial, we have analyzed the final result. Let me show our result of P3 part. 507 patients were randomly assigned. 254 patients in ODG group and 248 patients in LADG group were included in efficacy analysis. In our trial, to ensure high standards of surgical quality, participating surgeons were satisfied by the endoscopic surgical skill qualification system. Regarding short-term outcomes, no significant differences were observed in grade 3 and higher postoperative complications between the two groups. The hospital mortality was 0.4% for both the groups. Primary endpoint of our trial was 5-year RFS. As a result, the 5-year RFS was 74% and 76% for ODG and LADG groups respectively. The hazard ratio was 0.96. We successfully proved non-inferiority. So we concluded LADG with D2 lymph node dissection for locally advanced gastric cancer was safely performed by credentialed surgeons and was comparable to ODG in terms of 5-year RFS and 5-year overall survival. The laparoscopic approach could be a standard treatment for locally advanced gastric cancer. Now we will analyze the further oncological safety such as stage 3 disease, T4 disease, or N3 disease, or obese patient, and so on. This time, we could also show non-inferiority of laparoscopic distal gastrectomy for locally advanced gastric cancer, as well as CARE study and CERA study. These global evidence from each country could contribute to clinical decision for the gastric cancer patient. On the other hand, there are several concerns of laparoscopic total gastrectomy for advanced gastric cancer. LTG is technically demanding procedure due to lymph node dissection along the splenic artery or splenic hilum, esophageal anastomosis at higher position, and more advanced disease such as large type 3 or type 4. To make evidences, several clinical trials are ongoing. We are waiting for these results in the future. We have established global evidence of lap gastrectomy so far. What's next? Our clinical question. Our focus is moving to whether lap gastrectomy is safe for such as bulky lymph node metastasis, direct invasion to adjacent organs, UGI cancer, large type 3 or type 4 disease, preoperative chemotherapy, conversion surgery, and elderly patients. LTG for those regions are not only technically demanding procedure, but also the lack of evidence regarding the safety and efficacy. In our in-house clinical trial, we are conducting the phase 2 study of lap gastrectomy after chemotherapy. This is a case of preoperative chemotherapy for type 4 gastric cancer. BMI 36 and severe obesity were observed. You can see blue liver. In infrapyloric space, the landmark are pancreas and duodenum, and the number 6 lymph node. So we ligate its right epigastric vessels like this. And to secure the good operation field is very important. The final view after number 6 lymph node dissection. This slide shows the global evidence of lap gastrectomy for patients with neoadjuvant chemotherapy. Solid evidence of safety and efficacy of lap gastrectomy for patients with NAC is still not enough. Therefore, the result of several studies is expected in the future. Recently, the development of new anti-cancer drugs and highly effective regimens has resulted in remarkable tumor shrinkage with chemotherapy, whereby some stage 4 gastric cancer patients with a good response to chemotherapy have been able to undergo curative resection followed by long-term survival. This slide shows the treatment strategy of stage 4 gastric cancer introduced by Professor Yoshida in Japan. Actually, we have experienced conversion surgery year by year. According to Yoshida's category, FACO group conducted international retrospective cohort study, COMBO GC1. Conversion therapy for stage 4 gastric cancer is safe and could be a new therapeutic strategy to improve the survival of the patients, especially those with early resection. Regarding UGI cancer surgery, there are several concerns such as extent of gastric resection, extent of lymph node dissection, or type of reconstruction. In UGI cancer surgery, complication rates to anastomosis is concerns. This slide shows the post-operative complications of endoscopic surgery for UGI cancer according to the latest UGI survey. The rate of leakage was around 15% in endoscopic surgery. Previous retrospective study shows high incidence of anastomotic leakage around 10%, either esophagogastric anastomosis or esophageal anastomosis. Therefore, safe anastomosis in endoscopic surgery for UGI cancer must be established. This slide shows surgical strategy for UGI cancer in our institute or at university. Safe techniques, especially for anastomosis, should be considered for individual cases. In Japan, the number of cases undergoing robotic gastrectomy is dramatically increasing. The reason why may be that this procedure was covered by national insurance in 2018. In 2022, additional insurance for instrument has been available, and the criteria for consult surgeon have been expanded. In Oita University, we have also introduced this procedure and built a surgical team like this. Regarding global evidence, there were several solid evidence of robotic gastrectomy. In Japan, short-term results from RCT in single institute was reported, and now JCOC conducts other RCT to confirm the safety of robotic gastrectomy for stage 1 or stage 2 gastric cancer. In addition, SUDA has demonstrated safety using the NCD big data in Japan. Collecting these data, technical feasibility of this procedure has been confirmed, but not in long-term outcomes. In summary of my presentations, we are actively developing a minimal invasive treatment for advanced gastric cancer and multidisciplinary treatment and function-preserving surgery, which emphasize the QOL for all gastric cancer or elderly patients. Furthermore, robotic surgery or AI navigation surgery may play important role in this field in future. Thank you very much for your kind attention. Good morning, ladies and gentlemen. It's my great honor to present in this symposium. This time I want...
Thank you very much for your kind attention. Thank you.
Yeah, Professor Etoh, thank you very much for this excellent presentation. Just
thank you.
One question. The conversion protocol that you showed for metastatic disease, if you go for neoadjuvant chemotherapy or pseudo-neoadjuvant chemotherapy, what protocol do you use in Japan? Which type of therapy do you give?
Yes, thank you very much. Important question. Regarding neoadjuvant or chemotherapy, we use the SOX regimen. It's one oxaliplatina regimen, and then we perform the surgery, including the laparoscopic surgery in Japan.
Is in Japan currently any evidence, or do you have any clinical situation where you do a perioperative chemotherapy?
Thank you very much. Also, very important question. At this moment, we don't have any solid evidence regarding the neoadjuvant chemotherapy. But now, we are JCOC study or another group is ongoing the established the evidence for the neoadjuvant chemotherapy.
Can I also ask, what is the, in your experience, the percentage of signet cell tumors at your institute or overall the data from Japan, and what is the R0 resection rate for gastric cancer in Japan? Just very broad.
Thank you very much. As you said, the signature cell carcinoma is an important character in the malignant disease. The population of the signature cell carcinoma is, I think, is around 10% among the tumor. But we don't change treatment strategy depend on the histological type, including the signature cell carcinoma just now. But we should evaluate the characteristics of the signature carcinoma in the near future.
The R0 resection rate at your institute?
As the resection for the signature cell carcinoma?
No, in general, for gastric
In
cancer.
general. Yeah, our resection rate is in your institute at least 80%. But it depends on the institute. Our institute in university, at another hospital with a cancer center, that depend on the institute, hospital.
Can I ask?
Almost, maybe the resection rate is 80%.
Thank you, Professor Etoh. And though initially there was some problem in telecasting, but it happened and we saw your slides and video so nicely. Just a query, whether do you think that in future the robotic will take over all the laparoscopic, this minimal invasive surgery for advanced gastric cancer?
Yes.
Robotic,
Yes. As I presentations, the indication of the lap surgery is expanding for the advanced gastric cancer, and the robotic surgery is rapidly increasing for not only the R gastric cancer but also the advanced gastric cancer.
Yes, there is one question.
In the future, the robotic surgery is the standard therapy in Japan.
Sir, I'm a surgeon from Kashmir. We have a very common problem of gastric and esophagogastric junctional cancers. Now that you said that the peri-op chemotherapy is still in a phase of trial in Japan, what is the common clinical practice of neoadjuvant approach in GE junction cancers at your place at present? What clinical staging do you opt for giving, or it's all upfront surgery over there till when the results come? Whether you give whether you give neoadjuvant chemotherapy at present for esophagogastric junction cancers. And what clinical stage?
Your question is neoadjuvant chemotherapy for UGI cancer.
Yeah.
That's right.
Yeah.
Okay. Yes. Yes, as we know, we are conducting the clinical trial for UGI cancer, the neoadjuvant chemotherapy, the FLOT regimen or DCS regimen. But just now, we don't have any solid evidence of the neoadjuvant chemotherapy for advanced UGI cancer.
So what is the practice at present over there? What is the practice other than the trial cases, whether you people still go for upfront surgery?
Yes, in my practice, first the SOX regimens performed is received, and then we perform the laparoscopic gastrectomy surgery for UGI cancer in the institute.
Okay, thank you.
Thank you very much. Thank you very much, Dr. Etoh.